And welcome to the Dr. Bob Show. We'll be spending most of this show talking about sinus infections. Do you know that there are different kinds? There are some that are short-lived and there are some that you just can't get rid of. The treatment for both is very, very different. We'll be learning the causes, we'll be learning the treatment, we'll be learning about what you can do about it. So there's going to be a lot of information on sinus disease. My guest is Dr. Mark Overholt. Dr. Mark Overholt is a board-certified ear, nose, and throat physician, and he deals with chronic sinus infections every day. Hello, I'm Dr. Robert Overholt. I'll be your host for the next 30 minutes on the Dr. Bob Show. Later on, we'll be talking, why does cholesterol cause heart attacks? And more people are becoming allergic. What's the best medicine? Is there one, or does it take two, or there's no hope? A lot of answers for you. A lot of questions are going to be answered. You'll want to stay tuned. We're talking with Dr. Mark Overholt, a board-certified ear, nose, and throat physician. We're going to be talking about sinus disease. Mark, welcome to the Dr. Bob Show.
Thanks for having me.
Tell me about the sinuses. Where are they? How many?
So the sinuses are in the face, basically. They're paired. You have two frontal sinuses over your forehead, two between the eyes that are called ethmoids, two in the cheeks that are called maxillary sinuses, and two back in the very center of the head called sphenoid sinuses. And they're air-filled cavities with normal nasal lining, if you will. And normally that nasal lining is healthy and thin, but when it becomes inflamed, then you have sinus issues.
So if you have an acute sinus infection, what does that mean?
So we look at sinus infections as acute or chronic, and the acute infections are for the most part viral. Probably 80% of all infections that occur acutely, where people come in with stuffy noses and mid-facial pressure and nasal drainage and misery and feel terrible, those are viral. And it's important to delineate between a viral and a bacterial infection, because obviously the viral ones don't respond to antibiotic therapy. And
so the viruses don't respond. It's a key issue, because people, when they get sick, they immediately want an antibiotic. You said that most of them are viral. So the symptoms that people come in are
viral infections can mimic bacterial infections.
Yeah.
So in the first 5 to 7 days, it's probably better to err on the side of conservatism. Assume that you're one of the 80%ers, viral infection.
So what does that mean? How do you treat that conservatively?
Decongestants, saline irrigation, conservative sort of supportive care, anti-inflammatories for your symptoms of pressure and discomfort and headache. And then if it worsens at the end of that first week, if you begin to notice that your symptoms are not improving but are getting worse, you begin to notice more exudative, infectious-looking nasal drainage, more facial pressure and pain, progressive symptoms, then it's reasonable to start thinking about an antibiotic therapy. And there's not really an accepted time period for antibiotic therapy for acute infections, but most of us would give a 10-day course of an antibiotic and then check back with your physician to ensure that you're responding appropriately.
Do most people respond before the antibiotic, the first 5 or 6, 7 days? You said saltwater irrigation, saline irrigation. What do you mean, saltwater spray?
Any of the above. There are misting saline sprays, there are neti pots, there are squeeze bottle irrigation sets, and there are even some battery-powered pressure washing devices that are much like a water pick we used to use for our teeth. And any of those are fine to lavage the nose.
So decongestants, anti-inflammation, saline sprays, and then after a period of time, if you start having discolored stuff, the antibiotic. Any antibiotic of choice?
Yeah, we tend to move to the amoxicillin derivatives, Augmentin first. Those are what we recommend. They're appropriate for the bacterial spectrum that cause sinus infections, and we would typically pair that with saline irrigations and probably with a nasal steroid. to try to get the inflammation out of the nose with a topical nasal steroid misting spray, many of which are now available over the counter.
And so you get pretty good results with that.
Excellent results.
And if you don't with the antibiotic, then what's the course there? How long before you start thinking of chronic?
Well, we live in a world of bacterial resistance today, and so that complicates treatment in some circumstances. And so if you don't respond to that first-line antibiotic, then your physician will generally change the class to a different type of antibiotic and give you another 10-day course. And we hope that you respond to that one. And if you look at today's bacteria that are out there, many of them are resistant to antibiotics because we've given so many antibiotics for viral infections. And so it's important for the public to know that your doctor's not being mean or lacking compassion. It's that they're trying to do the right thing for the general health of our population.
So what are some of the underlying causes? You said viral, that's when you cough at somebody. Are there other causes of acute sinus infections?
Well, sinus inflammation, sure. Allergies, are huge, and we who live in East Tennessee experience that right during this time of the year or in the fall, and we have lots of people that suffer from nasal stuffiness, and so allergy management is one of those things that's sort of a hallmark cornerstone of treatment for people that have stuffy, congested, runny, itchy, sneezy noses. And there are other causes, irritations from environmental hydrocarbons that irritate noses, perfumes. Some people have sensitive noses, and if they get around smokes or perfumes, and then
nose is pretty sensitive, isn't it?
It is. It causes a lot of misery.
Now, the sinuses, you said, are holes in the head. How do they drain normally, and what passageway do they have, and what happens if that's blocked?
Well, they have a defined drainage passageway. Each sinus does. Some of them share passageways in the head, and they drain into the nose. And if those passageways become blocked from chronic infection, closure of that opening, then oftentimes the treatment with medications is not successful, and then you need surgery. And we try to stretch treatment out to 12 weeks, and that's the defining moment where we say it's no longer an acute infection, it's now a chronic infection at 12 weeks. And many of those patients will require some sort of surgical procedure, of which there are many.
So you can have sinus infections that last 12 weeks. That's 3 months.
It sounds terrible, doesn't it?
Yeah, it really, really, really does. And people must be miserable with that. Is the treatment then different than you do when you have a sudden sinus infection that's a common cold type thing? Treatment going to be different?
Sure. If you have blockage in those areas we were discussing, then opening those areas of blockage can help you relieve the infection. And we're in a day of evolving treatments in that arena. We have balloons that we've talked about in the past that we can deploy in the office under local anesthesia to dilate the little ostia, the sinus openings, so that drainage can occur. We have office-based surgical procedures, and then we have our traditional endoscopic sinus surgeries, and we continue to get better in that arena. And I brought some show and tell items to show the audience today about what we might add with our surgery these days to help better the outcome.
So the chronic sinus infection, that's the one that people really, really are in bad misery, or is it the acute, the short term?
Both.
Both. And so the chronic has different treatment, is that right? Or is the treatment successful?
Treatment's successful for both generally, and so you just have to go through that graded spectrum of stepwise process and hopefully somewhere along the way you're better and you drop off, but there's an increasing intensity of therapy based on the severity of disease.
And that's what we're going to be talking about when we come back. Acute sinus infection is like the common cold, where you block up the sinuses, where they can't drain, where you get headache, where you don't feel good. And if that lasts 12 weeks, then we've got an entirely different treatment. And that's what we're going to be talking about when we come back, because that's when people suffer for a longer period of time. You'll want to stay tuned. We're talking with Dr. Mark Overholt, and we're talking about sinus infections. There's the acute, there's the short term, the one that we get where the sinuses are blocked and you're miserable. And we want to try and treat that without antibiotics. If you go a week or 5 days or 10 days with out an antibiotic and you're still having symptoms, need to call your doctor, probably need a course of antibiotics to get you well. If it doesn't get well in the last 12 weeks, that means it's called
chronic rhinosinusitis.
So why do you say rhinosinusitis?
It's just more inclusive of infection and inflammation in the nose and the sinus cavities, which function together.
So when they function together, if you've got rhinosinusitis, what do you have to do about those drainage areas that are closed? What's the treatment for chronic sinus infection?
It's to open those drainage areas, and so we've begun discussion about balloons to dilate the area, and the openings have little bony shells in the area where we dilate, and so it's not like where we used to stretch a heart vessel and it was all elastic tissue and could collapse back down. Now if we dilate those areas, there's actually bony remodeling in the sinus opening, and so they stay open. It's a tool. It's used in certain sinuses, predominantly the maxillary, frontal, and sphenoids, but not the ethmoids. The ethmoids are unique and are often the seat of chronic infection in people. They're a honeycomb space, and in those little honeycombed air cells, infection can set in. And the blood supply to those areas is not great, and you can treat and may feel better, but you may leave a little seed of infection from which your next sinus infection reblossoms. And so there can be a staccato pattern of infection better, and these people that have chronic sinusitis who are getting antibiotic therapy over and over again. If we can open them, we can eliminate that. And if it's simple and it's isolated infection in the maxillaries, then a balloon might be a great office-based procedure.
That balloon is called sinuplasty.
Balloon sinuplasty, yeah.
And that's where you open it up. And we've had a show on that. I want people to refer to that because that can be done in the office, frequently done in the office, opens up the hole, lets the sinuses drain. Next step?
Next step would be moving towards a more traditional endoscopic sinus operation, where, especially in those people that have ethmoid disease, really if you have ethmoid inflammation or infection that we see on the CT scan x-ray before surgery, which is the roadmap for our surgery, then you're going to require a more traditional operation. I will say we're doing more and more of the ethmoid work in the office now, but typically that's done in the operating room. And so you're basically opening up those little honeycombed air cells so that they can drain, and it improves plumbing. And that's part of the story towards health. The other one is medical management after sinus operation, because something caused inflammation in the nose that led you to get a chronic infection. And it's not just the anatomy or obstruction, it's a combination of the person's immune system and how it responds to challenge. It's allergy, it's irritation, it's obstruction, it's seated infection. And so you really have to take a whole look at all those things to be able to determine how I'm going to get that person better.
So if they've had an infection, a chronic sinusitis for a period of 12 weeks or longer, you just don't give them an antibiotic and leave them alone. You open it up, and then what do you have to do? How do you have to use medical management? What do you do?
So in the short phase, we will irrigate the nose to get out some of the crusting that's associated with surgery. But long term, it's things like topical steroid application, and we've traditionally used misting nasal steroid sprays or antihistamine sprays to help manage the mucosal inflammation. Sometimes now in tough patients, we're actually taking the steroid and putting it in nasal rinses as a better means to deliver that steroid further back in the sinus cavity so that it makes better contact with mucosa, the lining of the sinus, to keep the inflammation out, keep polyps from returning. And we even have some nice new things that we can use intraoperatively to help us transition towards normal health. And I brought a couple of those today to look at.
No, let's look at those and tell me about what they do.
So smart scientists have come up with polymers that will dissolve in the sinus cavity. And here's an example of one.
Now, you can't put that in the nose, it's too big.
Right, it crimps down and almost like a little Chinese finger cot, if I can get it down here. It gets loaded in a device and then it expands in the sinus cavity and stents the cavity open. And not only does it stent, decreasing scarring, but these little polymers are impregnated with steroid. And so in this particular device, the steroid gets leaked into the soft tissue over 30 days. This implant dissolves in 30 to 45 days.
It dissolves itself, and it's giving you 30 days of steroids to take away the inflammation, the swelling, to let the sinuses drain. That's pretty techno. That's pretty good. Is it hard to do? Hard to put that in there?
It's simple. It basically gets crimped down and placed in this little device, and we slide it up in the sinus cavity and deploy it, and it expands and does a beautiful job. This one is the one we use most commonly. It's in the ethmoid cavity. This one here is a smaller one. It's called a mini, and it crimps down in almost an hourglass shape, and it fits nicely into the frontal sinus recess. The frontal sinus, which has been a tough area in the past for us because the openings tend to close back up. This has led to a higher patency rate and more open frontal sinus long-term for patients.
So does that dissolve also?
This device, like that one, is a 30 to 45 day polymer dissolving, 30-day drug delivery device.
So that's just like you don't have to do anything. The medicine, it's in there, and the medicine's being eluted, being given out there, and it's a steroid medication, and it takes away the inflammation, and so, wow.
Yeah, and it's great because in the past we had to give people prednisone or oral steroids, and those oral steroids work wonderfully, but they come at a price. There are side effects. You can have bony fractures, and long-term utilization can lead to cataract formation and other issues. And so while they're wonderful medications, we use them with caution.
So those dissolve. What else is new in addition? How is technology advancing?
So this is another device that comes from the same company, and this is an in-office stent. A little different in shape. It goes up in the ethmoid cavity, has its own little deploying device as well. And this is used in patients that develop polyps, a real tough group of patients who have chronic rhinosinusitis. Their nasal lining is more inflammatory than even the bad sinus patients. And their rate of recurrence of polyps is 80% or more. And so this device can be put into the sinus cavity. It's different. It stays in and leaks drug out for 90 days. So for 3 months, you get steroids in the lining. Doesn't go in the body systemically. You don't have any systemic side effects from it, but it's a wonderful little device.
And so that's especially used for people that have the chronic sinus infection with polyps in there, which is really, really quite common because of the inflammation. How long does that stay again?
This device dissolves in 90, or it leaks drug in 90 days and dissolves in about the same time frame. So a 3-month device now, 3 times the amount of drug that's in the smaller device, and it's wonderful. This will change the way we practice. We'll begin to offer patients that have polyps an in-office treatment as an option to try to avoid surgery, and the results clinically in trials have been excellent.
To me, that's just fascinating that you can put medicines inside the sinuses instead of every day having to go through steroid washes in that type situation. So at the end of 3 months, do you have the experience of what kind of results that people have?
70% of people see the polyps go away. So you see significant reduction in polypoid disease and the symptoms that the patients complain of.
So what do the patients tell you when they no longer have that chronic sinusitis?
They feel great. They have kick in their step again. They're ready to go meet the world and get out and engage. It's a real liberating event for people that have chronic sinus infections. And smart scientists in our country need money and funding for research, and it's from research money that we get these great devices. There is another horizon, I think, that's coming out there for people who have chronic sinus disease. People know about Inbrel and some of the other medications that have been used in rheumatoid arthritis. They may see some advertisements for antibodies that are now used, or biologic medications used in cancer. And actually, we have a new drug that's available, dupilumab, for sinus polyps. And it's a monoclonal antibody, so it's an antibody just like your body makes.
A biologic, we call it.
Right. It's directed against a certain cell or a certain chemical called interleukin-4, and it reduces the inflammatory response that leads to polyps. It's, I think, a real horizon in medical management for sinus disease.
It makes me smile to know that we're getting better and better and better. Mark, you're a great teacher. Thank you for telling us about opening the sinuses, about steroid eluting stents, now for 3 months worth, dissolve themselves, and now there's biologics that are coming on top of that, and people feel up, ready to go. Thank you so much for coming to Dr. Bob.
It's great. It's an exciting time to be a physician, and it's just an honor.
Wow. So if you've got chronic sinus disease, know that you don't have to live with that anymore. There's things that can be done. You're going to want to stay tuned. We're going to be talking, how does cholesterol really cause heart attacks? And more people are becoming allergic. If we've got time, we'll talk about what's the one best medicine that you can take for your allergies. I want to thank Dr. Mark Overholt. Wonderful discussion on sinusitis. If you've got sinusitis that's chronic, know that there's good treatment. Now let's get to questions from you, the viewer, that I think will be important to your health. Question number 1. Dr. Bob, how does cholesterol associate with a heart attack? Well, we know that if people have high cholesterol, we need to bring it down. Why is that? Well, cholesterol floats around in the bloodstream. We need some cholesterol, but if it gets high, it begins to deposit in the lining of the blood vessels, and that's where the problem is. There gets to be cholesterol plaques in the arteries that supply the blood to the heart, also heart arteries to the rest of the body. So those cholesterol plaques, if by chance they burst, then think of an airbag in a car that suddenly expands. Well, that's what happens in the blood vessel. So there's suddenly a blocked blood vessel. We used to think the cholesterol got just more and more and more. Now we know it explodes into the artery. That's why if you've had a heart attack, we need to be taking blood thinners afterwards and also beta blockers afterwards. The blood thinners, when that airbag expands inside the blood vessel, it keeps the platelets from causing a clot there. And so the vessel doesn't clot. And so that we can keep people from having recurrent heart attacks. There's also some ability to do a cath right after you have a heart attack. So if you get chest pain, crushing chest pain in the middle of the chest, 911, get to the emergency room quickly. They can take you up to the cath lab. They can put a stent in, same kind of stents we have basically for the sinuses, and then know that they can put you on medication where you can start to exercise, use medications properly, that you can reestablish good health for your heart. Question number 2, Dr. Bob. Are there newer medicines for allergies? Well, that's a good question. I'm an allergist. There's increased incidence of allergies. Now, some 30 to 40% of the entire population has underlying allergies. Is there one good medicine? Well, yes, there's going to be. Let's talk about the allergic reaction. There's a sudden phase, a short phase, an acute phase, and that's where histamine's released when we're itchy, sneezy. But the worst problem is 2 hours later, there's a recruitment of cells to the nose that cause swelling and stuffy nose and sniffles and snorts and drainage and headaches and blocked head and sometimes sinus infections that can be chronic. So what can we do about that? The best medicine that you can take is an intranasal steroid. So that is a cortisone spray that we put on the nose. It tells those cells that are causing the congestion to get out of the area. It also will block the histamine release. So intranasal Flonase, you can get it over the counter. When you use it, spray toward the outside. If you spray straight up, some will get on the septum and you'll start getting the most common side effect, which would be nosebleeds, just a little bitty, not gushers, but just when you blow your nose, there'll be a little blood on the Kleenex. And so know that Flonase is the best medicine. Now, the real best would be Flonase, an intranasal steroid, plus a non-sedating antihistamine. But if you just use the Allegras, the Zyrtecs, the Claritins, then you're going to have problems because it'll only take care of itching and sneezing. You have to add an intranasal steroid, an anti-inflammatory medicine. When you take 2 medicines, they're twice as expensive. So the winner of the best medicine for you is going to be intranasal Flonase. It's a cortisone spray. It's not absorbed significantly, so it doesn't cause those side effects that we have of steroids. So know that we've got those medicines and that they can help you. Now that's all the time that we have for this show. Remember, we want to be exercising those 4 things. Exercising is probably the best thing you can do for everything. It will lower your blood pressure. It will help you lower your weight. It'll get rid of sodium. It'll get rid of stress. You'll feel better. You'll have a runner's high. Eat properly. You know, our problem in the United States is we eat too much food. So we're marketed to eat food. So look at your plate before you eat. Eat small amounts of food. Eat what you want, but eat small amounts. It's portion sizes. Sometimes even 6 meals, but one of those meals might be 1/4 of a sandwich, or stay away from the bread and just have pure meat and pure fruits and pure vegetables. Once you get used to that, you'll enjoy that type of eating. Sleep, 7.5 hours of sleep. Oh, there's so many things that can interfere with sleep. So be sure you're getting 7.5 hours of sleep. How do you do that? Well, you go to bed at the same time, you get up at the same time. You know what it's going to take to have 7.5 hours. Be sure the room's quiet. Be sure the covers are good. Be sure you're not taking any medicines that interfere with sleep. And most of all, what do we like in the Dr. Bob Show? You all know it. It's that laughter in your life. When you giggle, you do stay healthier. Your immune system works better. So laugh a lot, giggle a lot, and you'll stay healthy.